Welcome back to the Deep Dive. Today, we are opening up a file that, for many people, and especially men of a certain age, it comes with a very heavy, very scary label attached to it. We are talking about prostate cancer. And, usually when you hear those words, the mind just jumps straight to the worst-case scenarios.
It's almost a reflex, and it's completely understandable. The word cancer just carries a weight that is very hard to shake.
It really is.
But the sources we're looking at today, and specifically we're digging into a very dense, very comprehensive medical text, Chapter 64 on prostate cancer, they paint a picture that is so much more nuanced than that general public perception.
That is exactly what struck me right away in the reading. There's this central paradox. It's right at the start of the material. We're looking at a disease that is often described in the medical literature as indolent.
Which is really just medical speak for lazy.
Yeah,
It's slow-moving.
A lazy cancer. It says here that when it's localized, when it's still inside the prostate, the cure rates are incredibly high. The medical arsenal we have to just wipe it out is huge.
It is.
But, and this is the paradox, once it escapes that local environment, once it advances and moves out of the prostate, it remains incurable.
And that is the tension. That's the tension that defines this entire field of medicine. You have a disease that many, many men will die with rather than die of.
I've heard that statistic.
Yeah, you've likely heard it. If you autopsy men over the age of 80 who died of, a heart attack or a stroke, a huge percentage of them have prostate cancer and they never even knew it. But, and this is a critical but, if you miss that window where it turns from the lazy, indolent type into the aggressive, fast-moving type, the whole game changes completely.
So our mission today is to really decode that machinery. We aren't just going to talk about getting checked in some kind of generic sense. We're going to look at the cellular biology, the complex hormonal feedback loops, which are, I have to say, fascinating.
They really are.
And the pharmacology that doctors use to try and really outsmart the tumor.
We want to equip you, the listener, with the vocabulary to understand the logic behind it all. Why does a doctor look at one patient and say, we need to operate immediately tomorrow, and then look at another patient with the exact same diagnosis and say, let's just watch it and do absolutely nothing?
And that idea of doing nothing, observation or watchful waiting, that has to be the hardest psychological hurdle for a patient to clear.
Oh, absolutely.
But to understand why it's a valid medical strategy and not just, negligence, we have to start at the bottom. We have to look at the anatomy of the enemy.
Let's look at the map. So section 1, the pathophysiology.
The origin story. Okay, so we know the target is the prostate gland. But when we look at the slides under a microscope, what are we actually seeing? What is this thing?
What you're looking at is what's called a malignant neoplasm. But specifically, and this is really important for understanding how it behaves, over 95% of these cases are classified as adenocarcinoma.
Okay, let's break that word down. Adenocarcinoma.
So, adeno refers to glands. This means the cancer is arising from the acinar secretory cells.
The factory workers.
Exactly. They are the cells responsible for producing the fluids that make up a portion of the ejaculate. Now, this is where the concept of grading becomes so critical. If you take a biopsy, a core sample of the prostate, not all prostate cancer cells are going to look the same.
And this is that differentiation concept the text dwells on. This is where the whole lazy versus aggressive distinction actually happens physically in the cells.
It is. It's the core of it. Imagine like a spectrum of identity for these cells. On one end, you have what we call well-differentiated tumors.
Okay.
If you look at these cells under a microscope, they still look somewhat like normal prostate cells. They're organized. They're trying to form glands. They still sort of remember what they're supposed to be.
They haven't gone completely rogue yet.
Not yet. They're technically cancer, but they're still, well-behaved citizens of the tissue. For the most part, they're moving slow.
And that's our indolent course.
That's it. Clinically, these correlate with that indolent course. They grow very slowly. They might sit there for decades and do nothing. But then on the other end of that spectrum, you have the poorly differentiated tumors.
The bad actors.
The really bad actors. These cells have lost their identity entirely. They're just disorganized sheets of cells. They don't form glands. They grow rapidly, and they carry a much, much poorer prognosis.
And this differentiation, so how much the cell looks like a normal cell versus, a monster, that's the basis for the Gleason scoring system, right? The thing you always hear about.
Exactly. The pathologist looks at the most common patterns of cells in the biopsy and assigns a grade from 1 to 5. A lower grade means well-differentiated, lazy. A higher grade means poorly differentiated, aggressive. They add the two most common patterns together to get your Gleason score.
So a score of, say, 6 is better than a score of 9.
Much, much better. A Gleason 6 is considered low-grade cancer. A Gleason 8, 9, or 10 is high-grade. That score is one of the very first things a doctor looks at to decide your fate, to decide the entire treatment path.
And the danger, obviously, is when these cells, especially the high-grade ones, figure out how to leave the prostate. The text maps out the exit routes pretty clearly. There's local extension.
Which just means growing directly into its neighbors, the bladder or the seminal vesicles.
Then there's the lymphatic system, which is like the body's drainage highway, and then hematogenous dissemination.
Spreading through the blood. And with prostate cancer, there is a very specific signature to its metastasis that I really want to highlight because it explains so many of the symptoms we look for later on.
You're talking about the skeletal connection.
Yes, the bone connection. While prostate cancer can go to the visceral organs, the lungs, liver, brain, adrenal glands, those usually aren't the first stops on the tour. The skeleton is the primary target for distant spread via the blood.
Why the bones? Is there a reason it prefers that real estate over, say, the liver?
It's a really complex interaction, this idea of seed and soil. The cancer cells are the seed, and the bone marrow is the fertile soil. The cancer cells release factors that essentially hijack the bone remodeling process, tricking the bone into breaking down and creating space for the tumor to grow.
So it's not just moving in, it's renovating the place to suit itself.
That's a great analogy. It is, but the result is that skeletal metastases, so spots on the spine, the hips, the ribs, are the most common site of distant spread, by far.
Which explains why back pain is such a critical symptom, which we'll definitely get to in the clinical section.
Yeah.
It's not just a muscle ache. It could be the cancer literally taking root in your vertebrae.
Precisely. And that's a red flag we can't ignore.
Okay, so we have the anatomy. We know what the cells look like, lazy or aggressive, and we know they have a particular fondness for traveling to the bone. Now, we need to understand the engine. What drives all this? This brings us to section 2, the fuel source. It seems like you absolutely cannot understand prostate cancer treatment without understanding hormones.
It is impossible. You might as well try to understand a car engine without knowing what gasoline is. The entire rationale for the majority of treatments, especially in advanced stages, revolves around the androgen axis.
The androgen axis.
The growth of the normal prostate, and by extension the cancer, is driven by androgens, specifically testosterone and its even more potent derivative, DHT.
DHT being dihydrotestosterone.
Correct. So think of the prostate as an engine.
Yeah.
Testosterone is regular unleaded fuel. It works, the engine runs. But DHT is high-octane racing fuel. It binds to the androgen receptors in the prostate cells with much, much higher affinity, and it tells the nucleus, divide, grow, survive.
So the goal of so many of these treatments is basically just to cut the fuel line.
That's the goal. But to do that, you have to understand the whole supply chain. We call this the feedback loop or the axis. And the text lays this out almost like a corporate org chart. It really is a perfect top-down management system.
So let's trace that supply chain from the pop. It has to start in the brain.
It starts in the hypothalamus. This is the command center deep in the brain. The hypothalamus releases a hormone called LHRH, luteinizing hormone-releasing hormone.
Okay.
It's the CEO sending out a memo. The memo says, we need production.
So the hypothalamus sends out the LHRH memo. Who's picking up the phone? Who gets that message?
The anterior pituitary gland. It's sitting right there at the base of the brain. You can think of it as the middle manager. When the pituitary receives that LHRH signal, it gets to work and releases two managers of its own, LH, which is luteinizing hormone, and FSH, which is follicle-stimulating hormone.
And these two managers, LH and FSH, they travel down through the blood to the factory floor, the testes.
Exactly. And specifically, the LH hits a type of cell in the testes called the Leydig cells. That stimulation is the signal that causes the Leydig cells to produce testosterone.
And what about the FSH? What's its job?
FSH hits a different set of cells, the Sertoli cells, and that helps mature the receptors and supports sperm production. But for our purposes, for cancer purposes, that LH pathway to testosterone is the main highway we care about.
Okay, so you have this production line creating testosterone. It's circulating in the blood. It gets to the prostate. And then what happens?
Then, an enzyme inside the prostate cells called 5-alpha reductase converts that testosterone into high-octane DHT.
And the DHT binds to the nucleus of the cell and says, grow. But, nature usually puts a brake on these systems. It can't just be a gas pedal stuck to the floor forever.
It's not. There's a negative feedback loop, and this is absolutely crucial to understand for the later treatments. When the brain, so the hypothalamus and the pituitary, when they sense high levels of circulating testosterone in the blood, they slow down.
They see the inventory is high.
Exactly. They reduce the production of LHRH and LH. It's the body's way of saying, okay, the tank is full, we've got enough, shut down the factory for a bit. It's an elegant, self-regulating system.
And the reason we are spending so much time on this specific mechanism isn't just for a biology lesson. It's because, as we're going to see in the pharmacology section later, we're going to hack this exact loop to treat the cancer.
We are going to hijack it. We are going to manipulate it. That is the entire basis of hormone therapy. We use the body's own communication lines to shut down that factory.
It's pretty amazing. But before we get to the heavy-duty treatments, let's talk about detection. Section 3 covers screening and prevention. And there was a plot twist here regarding prevention that honestly surprised me when I was reading. We're talking about chemoprevention, so using drugs to stop cancer before it even starts.
You're looking at the data on finasteride and dutasteride.
Right. And these are drugs that a lot of men might already know about. They're usually used for BPH benign prostatic hyperplasia, or just an enlarged prostate. They block that conversion of testosterone to the high-octane DHT.
Right. They block the 5-alpha reductase enzyme we just mentioned.
So logically, it makes perfect sense.
Yeah.
If you block the high-octane fuel, you should, in theory, prevent cancer from starting or growing.
That was the hypothesis. And the text references a massive study, the Prostate Cancer Prevention Trial, where they tried exactly this with thousands of men. And the initial headline from that study was great.
Looked amazing.
It did. The trial showed that patients taking finasteride had a relative risk reduction for prostate cancer of nearly 25%.
Okay, that sounds like a slam dunk. You take a pill, your risk of cancer drops by a quarter. Why isn't every man over 50 taking this?
Because of the catch. And it is a nasty, complicated catch that has been debated for years. While the overall number of cancers went down, the cancers that did develop in the men taking finasteride were significantly more aggressive.
More aggressive.
They were high-grade tumors, more Gleason 8s and 9s.
Wow, that is a terrifying trade-off. You lower your chance of getting cancer at all, but you increase the chance that if you do get it, it's the kind that kills you.
That's the paradox. Now, there's a huge debate about whether the drug actually caused the high-grade cancer or if, and this is the other theory, it just shrank the prostate glands so much that it made the really aggressive cancers easier to find on a biopsy, like finding a needle in a smaller haystack.
So it might just be a detection bias.
It might be. But at the end of the day, the result is the same. Because of that data and the uncertainty, the current guidelines do not recommend using finasteride or dutasteride for prostate cancer prevention.
It's a classic case of a drug hitting a surrogate martyr. It lowered the prevalence, but it failed the ultimate test, which is, does this actually save lives? Does it reduce mortality?
Exactly. And it hasn't been proven to do that, so we don't use it for that purpose.
Okay, so prevention with a pill is out for now. Let's move to screening. This is always a controversial topic. To screen or not to screen, the two main tools in our toolbox are the PSA and the DRE.
Right. PSA, or prostate-specific antigen, it's a glycoprotein, a type of protein produced by the prostate cells. The problem is right there in the name, it's prostate-specific, not cancer-specific.
So what else makes it spike? If I go get a blood test and my PSA is high, does that mean I have a tumor?
Not necessarily, not at all, actually. Almost anything that irritates or inflames the gland can cause a spike.
Like what?
Well, acute urinary retention can do it. Acute prostatitis, which is just an inflammation or an infection of the prostate, can send it sky high. Or just having BPH, a larger benign prostate, means you have more cells producing PSA, so naturally your baseline number is higher.
I read that even something like riding a bike for a long distance can do it.
It can. Anything that mechanically irritates the prostate can temporarily nudge the number up. That's why a single high PSA reading is never a diagnosis.
It's a smoke detector, not a fire.
Perfect analogy. It just tells you to go look. In fact, the source argues that PSA is actually most useful for monitoring a response to therapy after a diagnosis has already been made.
How so?
Well, let's say you have confirmed cancer and we treat it, say we remove the prostate entirely in surgery, the PSA should drop to 0, undetectable.
Because there are no more prostate cells to make it.
Precisely. If 2 years later that number starts to creep back up from 0 to 0.1, then to 0.2, we know the cancer is back somewhere in the body long before we can see it on a CT scan or an MRI. In that context, it's an incredibly sensitive tracking device. But as an initial finding device, it has a lot of false alarms.
Okay, and then we have its partner, the DRE, the digital rectal exam, the low-tech counterpart.
A physical exam, and it has its own pros and cons. The advantages are obvious.
Oh.
It's cheap, it's safe, and it gives the doctor immediate physical feedback. You can feel for hard nodules, asymmetry, things that don't feel right.
And the disadvantages.
It relies entirely on the doctor's finger. The text calls it high inter-observer variability.
Which is a very polite way of saying Dr. A might feel a lump that Dr. B misses completely.
Correct. A finger is not a precision instrument. And you have to remember, you can only feel the posterior part of the prostate, the backside. If a tumor is growing on the anterior or front side, you would never, ever feel it with a DRE. But the combination of the two, an abnormal DRE or a rising PSA, is what gives us the clinical picture needed to decide on the next step.
Which would be a biopsy.
The biopsy.
Let's say the screening was positive. We have a diagnosis. What does the patient actually feel? What are the symptoms? This brings us to section 4, clinical presentation.
And this brings us right back to that indolent nature we started with. The vast majority of the time, localized prostate cancer is completely asymptomatic. It is the silent phase.
Which is what makes the screening so high stakes. You feel fine, you look fine, but the clock could be ticking.
Exactly. As the tumor grows locally, you might start seeing signs of outflow obstruction because the prostate, remember, wraps around the urethra like a donut.
So it squeezes the pipe.
It squeezes the pipe, so you see things like urinary frequency, needing to pee all the time, hesitancy, you stand there and have trouble starting the stream, dribbling at the end, a weak stream.
Which, confusingly, sounds exactly like BPH, the benign condition that most older men get.
It overlaps significantly. You absolutely cannot tell them apart just by those urinary symptoms. But the advanced warning signs, the signs of metastatic disease, those are distinct. And remember where we said the cancer loves to go.
The bone metastasis.
Right. So advanced disease commonly presents with back pain and stiffness.
This is a really key takeaway for the listener. Persistent, unexplained back pain in an older man isn't always just arthritis or a bad back.
It absolutely warrants investigation, especially if it's a new kind of pain. And if those lesions on the spine go untreated, they can grow and lead to spinal cord compression. The tumor physically presses on the nerves. That is a true medical emergency. You might also see lower extremity edema, so swelling in the legs, because the cancer has spread to the lymph nodes in the pelvis and clogged the drainage system. Or you can just see general constitutional signs like anemia, fatigue, and unexplained weight loss.
Okay, so we've found it, we've staged it, we know the grade from the biopsy. Now comes the hard conversation in the doctor's office. Section 5, the decision matrix. This is where the patient and the doctor have to sit down and figure out a strategy.
And the very first thing we have to establish is the goal. The goal shifts depending on the stage. If it's early stage, localized disease, the goal is cure. You want to minimize morbidity and mortality. We want to wipe it out.
But if it's advanced?
If it's already spread, the goal shifts. It becomes about palliation, symptom relief, slowing the progression and maintaining quality of life for as long as possible.
The text provides a risk stratification table 64- that breaks this down very clearly. Let's start at the bottom with a very low or low-risk patient. So this is a guy with a small tumor, maybe a T1 or T2A, a low Gleason score, like a 6, and a low PSA.
Small, slow-growing, contained. For these men, the recommended strategy is often observation or watchful waiting.
Which sounds to a patient, I'm sure, like doing nothing. You found cancer inside my body and you want to just watch it.
It sounds like that, but it's technically called active surveillance. It's not passive. It involves regular PSA checks, maybe every 6 months, regular DREs, and even repeat biopsies periodically, maybe every year or two.
So what's the logic?
The logic is risk management. Why subject a man to the potentially life-altering side effects of surgery or radiation, which we'll get to? If the cancer is growing so slowly, it will likely never actually harm him. You are essentially betting that he will die of something else, old age, heart disease, long before the prostate cancer becomes a problem.
It's playing the odds. But the risk, obviously, is that you bet wrong. The cancer could progress.
Yes, that's the risk. If it accelerates between surveillance points, you might miss the absolute optimal window for a cure. That is a trade-off, and it's a very personal decision.
Now, if we move up the ladder to intermediate or high risk, the recommendation shifts from watching to action. We're talking about surgery or radiation. And Section 6 makes it crystal clear that these are not consequence-free interventions. This isn't like taking a mole off your back.
Not even close. Let's look at radical prostatectomy first. The goal here is to surgically remove the entire prostate gland, the seminal vesicles, and some surrounding tissue. It is potentially curative. If the cancer is entirely inside the box and you remove the box, the cancer is gone.
Sounds simple enough, but the anatomy of the prostate is tricky.
It's in a very crowded neighborhood. It sits right at the confluence of the bladder neck with the rectum right behind it, and it is wrapped in this delicate web called the neurovascular bundle, the nerves and blood vessels responsible for erection.
So the potential for collateral damage is huge.
Huge. The two big quality of life killers are incontinence and impotence, losing bladder control and losing sexual function. Now, we have nerve-sparing techniques where the surgeon painstakingly tries to peel those nerves off the prostate capsule, but they aren't a guarantee. Success depends on the surgeon's skill and how extensive the cancer is.
And what about radiation? Is that the easy way out for patients who want to avoid surgery?
It avoids the scalpel, but it has its own toll. Radiation works by damaging the DNA of the cancer cells so they can't divide, but it also causes collateral damage through inflammation of the surrounding healthy tissue.
So you get acute side effects right away.
Yes, during and shortly after treatment. Things like cystitis, which is bladder inflammation, making you feel like you have a bladder infection all the time. Proctitis, which is rectal inflammation, causing pain and diarrhea. Blood in the urine, swelling. It can be a very rough few months.
And the text mentions chronic side effects that can show up much later.
Years later, this is the part that often gets overlooked. Radiation is the gift that keeps on giving in a bad way. Chronic diarrhea, enteritis, urethral strictures, which is scar tissue that blocks the urinary flow, and yes, still impotence. It's just the slower onset than with surgery.
How so?
With surgery, you might wake up from the anesthesia and you're impotent. It's immediate nerve damage. With radiation, the damage to the blood vessels is gradual, so sexual function might decline over a period of a year or two as the vessels scar down. The end result can be the same.
There is one other surgical option mentioned in the source, that is, it's drastic. Bilateral orchiectomy.
Surgical castration, the physical removal of the testes.
I mean, in an age of advanced pharmacology, why would anyone choose that?
Speed. The answer is speed. Remember, the tests are the factory for 95% of the body's testosterone. If a patient comes into the emergency room with impending spinal cord compression, a tumor crushing their spine, threatening paralysis, you don't have weeks to wait for a pill or an injection to work.
You need to shut it down now.
You need to drop their testosterone to 0 today. Orchiectomy is the fastest, most reliable way to do that. It drops testosterone to castrate levels almost immediately.
But psychologically?
It is, for obvious reasons, unacceptable to many patients. It's permanent, it's visible, and it's symbolic. That's why the vast majority of patients who need to have their testosterone lowered will opt for medical castration.
Which leads us perfectly into Section 7, the pharmacological arsenal. This is where the science gets incredibly clever. We're literally using drugs to trick the brain into shutting down the whole system.
We're talking about hormone therapy, and the gold standard here, the workhorse for decades, has been the LHRH agonist. Drugs like Leuprolide, the trade name is Lupron, or Goserelin, which is Zoladex.
Now, I want to pause on the mechanism here because it confused me at first. The name is agonist. An agonist usually stimulates a receptor. It turns it on. If we want to shut down testosterone, why on earth are we giving a drug that stimulates the pituitary?
That is the central paradox of these drugs, and it creates a very dangerous initial window of time called the flare.
Okay, walk us through the flare. What happens?
So when you first inject an LHRH agonist, it does exactly what its name says. It binds to the pituitary receptors, and it screams, "Go!" The pituitary responds by releasing a massive surge of LH. Consequently, the testes get that signal, and they pump out a huge spike of testosterone.
So for the first week or two, you are actually feeding the cancer more of that high-octane fuel.
Exactly. You get a disease flare-up. If a patient has bone metastases, their bone pain will get worse. If they have a tumor that's close to extracting their ureters, it could swell and block their kidneys. If they have a tumor near the spine, this flare could theoretically expand it just enough to cause that paralysis we were trying to avoid.
That sounds like a complete disaster. Why do we do it? How does it eventually work to stop the cancer?
It relies on the pituitary getting overwhelmed and burning out. Imagine someone screaming in your ear constantly at maximum volume. For a minute you hear it, but eventually your ears ring and you just go deaf to it. The pituitary downregulates its receptors. It pulls them inside the cell. It stops listening to the constant LHRH signal. it crashes.
Ah, so you overstimulate it into submission.
Precisely. Once that happens, and it usually takes about a week, maybe 2 LH production drops to near zero, and as a result, testosterone production in the testes shuts off. You achieve chemical castration.
So you have to survive that initial storm to get to the calm. How do doctors manage that danger zone, that first week?
We use a shield. The standard of care is to prescribe an anti-androgen drug. We'll talk more about those in a minute, for a week or two before starting the agonist injection. This drug blocks the receptors on the cancer cells themselves, protecting them from that initial testosterone spike. Once the pituitary shuts down and testosterone levels have plummeted, we can usually stop the anti-androgen.
Now, there is a newer class of drugs mentioned in the text, GnRH antagonists. The main one is degarelix.
These are different. They are a much more direct mechanism. They don't stimulate, they are a direct block. They bind to the pituitary receptors and just say stop. No shouting, just a stop sign.
So no tumor flare.
No tumor flare. Testosterone drops to castrate levels in 7 days or less without that initial dangerous spike. It's a much cleaner mechanism, biologically speaking.
That sounds objectively superior. Why isn't everyone just using that one?
Because of histamine release, they cause significant injection site reactions. Pain, swelling, redness at the injection site are very, very common with degarelix, so it's a trade-off. But for a patient with severe bone pain where a flare would be truly dangerous, this is often the better, safer choice to start with.
We absolutely need to talk about the side effects of this medical castration. We are shutting off a man's primary hormone. This isn't just about the prostate anymore.
No, it's systemic. We call it androgen deprivation therapy, or ADT, and you are essentially inducing male menopause, but in a very rapid and severe way. Osteoporosis is a major long-term risk, a significant loss of bone density. Fracturing a hip can be just as deadly as the cancer in this older demographic.
So patients need bone monitoring.
Yes, the XA scans, just like postmenopausal women. And what else? Hot flashes, very common and can be very bothersome. Weight gain, particularly abdominal fat. Loss of muscle mass, fatigue, loss of libido, erectile dysfunction. It changes the entire body composition. Patients on long-term ADT need calcium, vitamin D, and a real focus on exercise to maintain bone and muscle health. It's not just taking a shot, it's a profound systemic change.
Let's look at those shield drugs again. The anti-androgens. Section 8 covers them in more detail. Flutamide, bicalutamide, nilutamide.
Right, so these work at the destination, not the factory. They don't stop the production of testosterone, they stop the reception. They bind to the androgen receptor on the cancer cell itself, basically occupying the seat so that testosterone can't sit down and deliver its grow message.
But we don't use them by themselves anymore, right? The text says monotherapy isn't recommended.
No. We learned that using just these pills is a weaker form of blockade. The brain eventually realizes that testosterone isn't working, and it just cranks up the production to override the block. So we use them in combined androgen blockade, CAB, paired with the LHRH agonists we just discussed to shut down production and block reception.
These drugs have some very peculiar, very specific side effects that jumped out at me in the text.
They do, and it's important to warn patients about them. Flutamide is famous for causing significant diarrhea. The text actually suggests specific dietary changes: soft foods, pudding, applesauce to help manage it. It also has a strange effect of turning the urine a bright amber or a yellow-green color.
Which would be very alarming if you weren't expecting it.
Definitely. And nilutamide. That one is even stranger. It can cause visual disturbances, specifically impaired dark adaptation. Patients might find they can't drive at night, or they have trouble walking from a bright room into a dark one. It takes their eyes a long time to adjust.
Wow.
And it also causes alcohol intolerance. A patient might have 1 glass of wine and experience severe facial flushing, nausea, and feel quite ill.
So, no wine with dinner if you're on nilutamide.
Yeah.
Now, there is a phenomenon in this section that I found to be the most fascinating and, frankly, terrifying part of the cancer's biology: the withdrawal phenomenon.
This is the ultimate example of the cancer's adaptability. It is evolution happening in real time inside a patient's body.
Explain this. So, we have a patient on combined blockade. They're on an LHRH agonist to block production and an anti-androgen pill to block the receptor. It works for a while, but eventually the PSA starts rising again. The drug is failing.
Right. The cancer is growing despite the drug. Your first thought would be you need to add a stronger drug or move to chemo. But sometimes the doctor will do something that seems completely counterintuitive. They will simply stop the anti-androgen, they take the pill away.
And what happens?
In up to 35% of patients, the cancer shrinks. The PSA drops. the patient gets better.
How is that even possible? You took away the medicine and the patient got better.
Because the cancer cells, under the pressure of the therapy, have mutated their androgen receptors. They have changed the lock on the door. The mutation is so specific that the key, the anti-androgen drug, no longer blocks it. Instead, the mutation allows that very same drug to act as a stimulant.
So the cancers learn to eat the poison.
In a manner of speaking, yes. The antagonist becomes an agonist, it becomes a feeder, the medicine becomes fuel. So by withdrawing the drug, you are removing the new fuel source the cancer cleverly created for itself.
That is terrifyingly clever on the part of the cancer.
It is. This androgen withdrawal response is a brilliant clinical observation, and it can buy the patient another 3 to 14 months of disease control without adding any new toxic drugs. It's a freebie just by stopping a pill.
But eventually, even that stops working. We reach the end of the hormonal road. And this brings us to Section 9, castrate-resistant prostate cancer.
This is the definition. When testosterone is suppressed to castrate levels by our therapies, but the cancer continues to grow anyway. We used to call it androgen independent, but we now know that's not quite right. The cancer's still using androgen pathways, it's just gotten much better at doing it, so we call it castrate-resistant.
So we have to move to the bigger guns. The text mentions androgen synthesis inhibitors, specifically a drug called abiraterone, or Zytiga.
Abiraterone was a complete game changer in this space. It targets an enzyme called CYP17A1.
That's a mouthful, CYP17A1.
It's a vital enzyme in the steroid production pathway. See, the standard hormone shots stop the testes from making testosterone, but they don't stop the adrenal glands, which sit on top of your kidneys, from making small amounts of androgens. And even more importantly, they don't stop the tumor itself.
The tumor makes its own testosterone.
In the advanced castrate-resistant state, yes. The cancer cells can actually evolve to synthesize their own testosterone internally. They become self-sufficient.
That's incredible.
So abiraterone shuts down that production everywhere. Tests, adrenal glands, and inside the tumor cell itself. It's a total global blockade of androgen synthesis.
But using it has some rules.
It does. Because it hits the adrenal glands so hard, it messes with your cortisol and aldosterone levels. So you have to take it with prednisone, a steroid, to replace what you're losing and prevent side effects like high blood pressure and low potassium. And there's a weirdly specific rule. It must be taken on an empty stomach. Food massively increases its absorption to the point of toxicity.
And when even the pills like abiraterone fail.
Then we have to turn to chemotherapy. For a long time, this was the end of the road. The first line is a drug called docetaxel, usually combined with prednisone. It was the first chemo shown to actually improve survival in this disease.
But it's chemo, with all that entails.
Yes. It's a systemic poison that targets fast-dividing cells. So you get the classic side effects, alopecia or hair loss, myelosuppression, which is suppression of the bone marrow leading to low blood counts, nausea, fatigue. It's a tough regimen. If that fails, we now have a second-line chemo called cabazitaxel, which is effective but has even more significant toxicity, particularly neutropenia, dangerously low white blood cells, and diarrhea.
Finally, at the very end of the chapter, there's a nod to the future. Immunotherapy, a treatment called Sipuleucel-T.
This is just fascinating science. It's an autologous cellular immunotherapy.
Break that down.
Autologous means it comes from the patient themselves. They take the patient's own white blood cells out of their body, send them to a lab, and expose them to a specific prostate cancer protein to train them to recognize the cancer. Then they infuse those newly educated immune cells back into the patient.
It's basically a personalized cancer vaccine.
That's a great way to think of it. It's science fiction becoming reality.
But there's a catch.
There is. It's very expensive, and the text notes that while it's approved for men who are minimally symptomatic, we don't have trials comparing it head-to-head with some of the newer hormonal interventions yet, so its exact place in the treatment lineup is still being sorted out by the medical community.
Wow. We have really traversed the entire landscape here. From that first rogue cell in the Acinar factory, through the hormonal hijacking and the clever adaptations, all the way to the most advanced immunological warfare.
It is a long and complex journey for these patients.
If we zoom out, what is the single biggest takeaway for the listener? We've covered a lot of very heavy science.
I think it comes right back to that initial paradox we started with. The whole thing is about balance. Prostate cancer treatment is a balance sheet.
You're weighing cure versus quality of life.
Exactly. On one side, you have the potential toxicity of treatment, and on the other, the potential toxicity of the disease. And aggressive treatment is not always the right answer. Watchful waiting isn't passivity, it's a strategic choice to preserve a man's life as he knows it for as long as possible. The so what here is that patients and their families need to understand that more treatment isn't always better treatment.
And that monitoring is everything.
Crucially, you cannot make these complex decisions without good data. Watching the PSA trends over time, the velocity of the change is far more important than panicking over a single number that might be slightly elevated.
I want to leave us with a thought that really lingers from that early indolent versus aggressive discussion. We have the technology now to find these well-differentiated, lazy tumors very, very early. We find them in men in their 50s who feel perfectly healthy.
We do, all the time.
It creates this profound psychological burden that we didn't really have 50 years ago. You are living with the knowledge of an enemy inside you. You know it's there. The doctor tells you it's sleeping right now. But the only way to be sure it hasn't woken up and turned into a poorly differentiated monster is constant, unending surveillance. You have to sleep with one eye open for the rest of your life.
That is the modern burden of early diagnosis. We have the ability to see things that we can't always predict the future of, and it requires a profound amount of trust between a patient and their doctor to navigate that uncertainty, to manage that anxiety, without letting it ruin the very quality of life you are trying to save.
A profound place to end. Trust, vigilance, and understanding the mechanics of the disease. That's really what we tried to build today. Thank you for walking us through this deep dive.
My pleasure. It's a tough topic, but knowledge is really the best weapon we have against the fear.
Absolutely. To our listeners, if you want to dig deeper into any of the pharmacology or the studies we mentioned, check the notes. Stay curious, stay vigilant, and we'll see you on the next deep dive.
Goodbye.
Bye for now.